Hello, and welcome to another episode of MCREG International On the Go. I'd like to introduce Dr. Greg Furman, in particular talking about a topic that is critically important for emergency medicine, and that is patients that are on factor Xa inhibitors that have severe bleeding. Greg, thank you very much for being here today.
Thanks, Brian.
How do we take care of patients that have factor Xa inhibitors on board? How do we reverse that?
So a lot of talk and controversy about how to manage a hemorrhage situation in one of our patients that's on a NOAC or a DOAC, particularly as they come into the emergency department or into our ICUs. Basic adherence to post-resuscitative techniques such as IV fluid administration, packed cells as necessary, platelets plus or minus depending on their clinical stability is something you would consider. But with a factor Xa inhibitor treated patient, you also have to think about other things in their history, particularly. For instance, when's the last time they took their factor Xa inhibitor? Because these drugs are renally cleared and they have very short half-lives. So if the patient hasn't taken that drug for several days, it's likely not meaningfully impacting the hemorrhage. But if they have just taken it within the last several hours, it probably is. Additionally, their renal function is also meaningful. These drugs are cleared through the kidneys, and by and large, impaired renal function will extend the half-life of these drugs and cause you to have to consider the anticoagulation a little bit longer. In terms of reversal, there is a reversal agent that is approved by the FDA called andexanet alpha, otherwise known as Andexxa, that is approved for the reversal of apixaban and rivaroxaban associated hemorrhage. What we know is that there are post-treatment thrombotic complications with any reversal agent, and andexanet alpha is not unique here. It's important not to compare across the spectrum of reversal agents the thrombotic complications. But bear in mind that patients are on anticoagulation for a reason, because they have thrombosis, either because of DVT-PE risk or because of atrial fibrillation. So once you reverse a patient on these agents, they will immediately revert to their pre-reversal state. So they have some thrombotic risk. So the risk of thrombosis will never be zero in these patients, obviously. For 4-factor PCCs and warfarin, the risk of thrombosis is about 4%. Andexanet alpha for factor Xa inhibitors is about 9% in most of our studies, and idarucizumab is about 4%. You shouldn't compare all these agents because the patient population is different in each of these studies. And this cartoon depicts a lot of the available data with respect to reversal agents and anticoagulant. On the left, you see warfarin and FFP and PCCs. In the middle, you see the Andexxa full study population. Again, I call your attention to the thrombotic risk at the bottom, which is not negligible, but seemingly similar across the spectrum. In addition, the hemostatic efficacy is also excellent across the board here. If you look at andexanet alpha, 80% hemostatic efficacy is shown in the Andexxa 4 study population on the efficacy population. It's important to recognize that the time since last dose in the Andexxa 4 study was about 12 hours. So the half-life of rivaroxaban is about 11 to 13 hours in a elderly population, so that's about one half-life. That's about standard across the board in this population. So this cartoon nicely depicts kind of a universal algorithm of life-threatening bleeding on a subject that is anticoagulated. And I'll call your attention to the factor Xa inhibitor, which is the bottom portion of the slide, which really calls your attention to knowing when the last dose was given of these agents, because of what I talked about earlier. The half-lives are very short, so if you're greater than 8 to 12 hours after the last dose, the anticoagulation of these agents is trailing off significantly. It's a really meaningful data point to know. Either get it from the MAR, which is the medication administration record from the nursing home, or some way find out when that patient last took their agent is a real important feature.
I think a really important point that you made, and I want to make sure that the audience understands this, is that once you reverse this patient with andexanet alpha, you put them in back in their native prothrombotic state. You discussed that, but I don't think that can be emphasized enough that you need to get the patient anticoagulated again as soon as safe, as soon as you've reversed the bleeding. And can you talk about that?
Sure. It's often a discussion that emergency physicians aren't confronted with because we aren't taking care of those folks at the discharge portion of their hospital stay. But it is critically important that the hospitalist or the surgeon caring for the patient in the hospital engages either the cardiologist or the neurologist, oftentimes in an ICH, on when a patient can feasibly be re-anticoagulated. Because what we do know is once you put the patient back on their oral anticoagulation, their thrombotic risk goes down to 0. We know that from the INDEXA 4 trial, that no patient had a thrombosis once they were oral anticoagulated again. Now, it may be a little bit difficult to envision anticoagulating a patient that just had an ICH, but at some point in time, you have to embark on that discussion.
Excellent. Thank you very much. And thank you very much for watching MCREG International on the Go.